Marajo! Thank you, everyone, for joining us today. And first, I want to introduce myself. My name is Wendy Leonard, and I am a physician in the United States. I take care of patients with HIV and tuberculosis. And I founded the Ihangane Project with the help of Dr. Jean de Dieu in Yerabega several years ago. And we began the Ihangane Project after being so inspired by your dedication to your community despite the limited resources that you have available. And at that time, I made a promise to Dr. Jean de Dieu and the community of Ruli to bring as many resources back to you as possible. It was actually Dr. Jean de Dieu's idea to begin the Nutrition for HIV-Exposed Infants program many years ago, and so we are very proud to see it blossoming today with all of your help. I especially want to thank Dr. Avit for his continued support of the Ihangane Project, and Sister Carmen, and all of the hospital and health center staff. I want to thank all of you from the health centers as well for your very hard work in implementing the NHI Clinical Program. We are very aware that you are extremely busy, and we have added to your work. We're very grateful for your commitment to your community and to the program. And I also would like to thank Uamahoro, Delphine, and Stephanie Blunt for their very impressive commitment to making this program work at all of the health centers. So one thing that you are aware of is that part of this program is about collecting information related to each participant in the program. This data is used to help follow the child over time and to improve your ability to make good diagnoses and choose appropriate treatment. In addition, we can use this information to identify areas that we are doing well in the program and areas that may need additional support. Our goal is to utilize this information, otherwise called data, to improve the quality of healthcare for all people in the Ruli catchment area and in Rwanda, as well as to help you gather the resources that you need to do your jobs well. Believe it or not, many of the challenges that you are facing in the NHI Clinical Program are very similar to the challenges that we face here in the United States. We utilize a concept called continuous quality improvement, and I thought I would share this concept with you here today and also share some of the situations that we have had here in the United States. Continuous quality improvement is a process with several steps. The first step is to collect baseline data. This data will give us the opportunity to identify strengths and also identify areas in need of improvement. Then we study the areas where we are performing poorly so that we can understand why. The next step is to develop an intervention to improve this area. And then lastly, we collect the data again to assess for improvement after our intervention. I would like to give you several examples from our HIV clinic in the United States. This list tells you of all of the indicators that we are following for our HIV positive patients in our clinic. We wanted to find out how well we were doing with each of these indicators. So in 2011, we collected baseline data for our clinics to see how we were doing. We found, for example, that 100% of our HIV positive patients were receiving Bactrim when they needed it. Yay, we were excited. But we also found that only 32% of our HIV positive patients were being screened appropriately for tuberculosis, and only 42% of our HIV positive women were being screened for cervical cancer. Our next step was to understand why. For tuberculosis screening, we found that the test was hard for providers to remember, and it required patients to return to clinic on 2 separate days. So our intervention was twofold.
we chose to change the test that we used to screen for tuberculosis so that it would not require so many patient visits to our clinic. We also designed a way to remind ourselves as clinicians to order the test. We were very pleased with our results. As you can see, in 2011, we only screened 32% of our patients, but by 2012, 83% of our patients had been screened. We still have not reached 100%, and that is the process of continuous quality improvement. One day we will. Pap smears are another issue that we were not doing well in. Pap smears are the way to screen for cervical cancer for HIV positive women in the United States. When we first analyzed our data, we found that less than half of the women were receiving the screening. We then studied the problem. When we looked closer, we found that most of the women were receiving this test, but we were not recording it correctly in our fiche. So as you can see, 1/3 of the women had actually been receiving the test, but it had not been documented correctly. So our intervention was to improve documentation within our charting. So with improved documentation, we discovered that only over 70% of the women were actually screened. This again is not 100%, but we are heading in the right direction.
So as you can see, we used data to help our patients. In both of these cases, we used the information that we collected to improve our ability to take care of our patients. What we did do, we changed how we performed our testing, we improved our documentation, and we found ways to better trust the data or the information that we were collecting. What we did not do was discipline anyone for doing something badly. What I wanted to emphasize through this process was the importance and benefit of accurate, correct data and information, because our ultimate goal is really to have a healthy society and especially to have healthy children. I hope that this information has helped, and I very much hope that you enjoy the day, and I wish I could be there. Hopefully I will meet you all in September when I travel to Rwanda. Munsi Muiza.